So welcome all of you on board. Yesterday we just started obstetric anesthesia. So we will just continue. We just in the first session we just try to just figure out how pregnant patient is different than other patients if you are anesthetizing them for any non-obstetric surgery other than like cesarean section. If you are anesthetizing any pregnant patient, what is different and what are the challenges and how will you manage those patients? Okay, so before we just go into I was just thinking to target common scenarios which are being asked in any sort of exam, whether written exam or viva exam. Okay, so you will start from obstetric hemorrhage. Okay, so how do you just classify different types of obstetric hemorrhage? Can anyone tell? How do you classify obstetric hemorrhage? Yes, Zishan, would you like to say something? Can you hear me? How will you classify obstetric hemorrhage? Like how do we classify it? Zishan, can you hear me? Yes, Sohaib, you want to tell?
Sir, antepartum, postpartum.
Yes, antepartum and postpartum. Okay, so what are common causes of antepartum hemorrhage? Either it is painful or painless. So which conditions will be painful? Like painful causes of antepartum hemorrhage? It will be either abruption, it will be either uterine rupture, okay, and painless will be placenta previa. Okay. Any other thing related to antepartum hemorrhage, Jamil? Is there any problem in voice? Are all of you able to listen to me?
Yes, sir, we can listen to you.
Yes. So what other common causes of antepartum hemorrhage?
Ruptured ectopic pregnancy.
Okay, fine. What else? Ruptured ectopic pregnancy is classified in antepartum hemorrhage?
Yes, sir.
Okay. What else? Yes, Arsalan?
सब bleeding disorder हो सकती है.
Yes, there can be bleeding disorder. Okay. What else?
सब blunt trauma.
Blunt trauma. Okay.
Miscarriage.
Okay. What else?
So uterine rupture.
Yes, uterine rupture and abruption we have counted in painful antepartum hemorrhage. Okay. And what will
we can call it like 4 T's.
Okay.
Tissue, trauma, thrombin, and tone.
Okay.
Uterine tone is not okay. Tissue means retained tissue of conception, and trauma is like cervical or vaginal ligations, and the fourth one.
Yes, you are right, but these are postpartum. Okay, so postpartum are usually what you are telling. Okay, so tissue will be retained, placenta, trauma, and for example, you did not mention placenta accreta, increta, percreta. Can someone just explain what is accreta, increta, percreta?
Yes, sir.
Yes, Assalamu alaikum.
Yes, sir.
Walaikum assalam.
If anybody is, yes, yeah, Dr. Salam, yes, please continue. Yes.
Okay,
Sir, accreta, it is a condition in which जो endometrium just touches the myometrium, and in increta it's deep in the myometrium, and in precreta it's outside the uterus.
Percreta. It is percreta. Okay.
Percreta, sorry.
It
Sorry,
is invading out of the uterus and invading in peritoneum, any viscera. It can. So the worst is percreta. Okay. Okay. So
Sorry, sir, I just make a mild correction. Just accreta is inversion in the endometrium, and increta is inside the muscular valve is myometrium, and percreta is outside the serosal valve of the uterus. It might be just outside, and it might be invade to the other organs.
yes,
yes,
A
you are
is
right.
mucosa, I is muscle, and percreta is per is means through and through. So it is called as
Yes,
per.
outside. Yes.
So this is so placenta, previa, accreta, increta, percreta. These are nightmares for any obstetrician, and it can be presented either as anticipated, in which you know about the diagnosis, or it can any anesthetist can face it unanticipated, like you were doing a normal cesarean section, it was not diagnosed, and suddenly patient bled like anything. Okay.
Yes. If you allow me, sir, I just tell you the correlation between the number of CS and the risk of placenta creta or percreta.
Okay.
If there is no previous CS, then there is a risk of accreta is only 0.3%.
Okay.
And after one CS, it will be 4%. After two CS, it will be around to 10 to 11%. And after patient third in cesarean, it will be risk of 60%. And after fourth, it will be more than 75%. 85%, sorry. Right, but I remember. As the number of cesarean increases, there is an increased risk of placenta creta or increta.
Okay. Okay. So, like how to manage an unanticipated obstetric hemorrhage? Yes.
Sir, our approach will be ABC. If the patient is already anesthetized and intubated, then our goal will be to the directly to the circulation, maintain the blood pressure, and maintain the intravascular volume. Immediately, we request the close communication with the the obstetrician, and if it's possible, he can clamp the uterine artery, and or immediately we draw the blood sample. And if there is a delay, we can immediately take the O negative blood.
You did not
Announce
mention about call for help.
Call for help, yeah, call for help, and announce massive blood transfusion.
Okay. What is massive
And,
transfusion protocol?
Then during this, we need a high number of blood transfusion, means more than more pack RBCs and FFP, precipitates, and platelets. And also we need
No, actually, if you are able to explain it in a better way. Massive transfusion protocol is a hospital-based protocol in which uncross-match blood and blood products are being called according to the availability, and according to the protocol, they will have a set of O negative or O positive blood, PRBCs, FFPs, scrap precipitate, and so when it is announced massive transfusion protocol, immediately that uncross matched blood will be reaching the OR.
Available to the OR.
Yes. So this is one is a call for help. Other is massive transfusion protocol. They can ask you about massive transfusion protocol separately as well. Okay, and it's part of answer of this question. And for the MCQs, they can have an MCQ with the scenario in which they will be giving you some picture of hemorrhage, and there will be like either it will be painful or either it will be painless, or there will be some hint towards the cause, or there will be some question related to the management. Okay, so we will just go a little haphazard and then we will try to fill the gaps in the question. So one question, Zishan, what are the factors in this scenario which can add to bleeding or which can prevent bleeding? What are the factors which will enhance the chances of bleeding, and what are the factors you will be targeting? Okay.
Sir, number one, uterine tone. If the uterus is not contracting, the bleeding will be prolonged. If the patient has already bled a lot, she can have dilutional coagulopathy. That can lead to more bleeding.
What else?
Even with the massive transfusion protocol, we can also have dilutional coagulopathy.
Okay, what else?
These patients can even land into DIC.
Okay, you are going far behind, far forward. You are missing the things which are there. Then you are telling the points which are to be told at the last. You are missing the important things. What about hypothermia? What about use of inhalational agents? Okay.
Yes, right.
So what about use of cold fluids? Okay. So these are more important things than what you are telling. Anything else which can be done at that time? Like you have to take large bore IV cannulas. You have to improve the peripheral circulation. Okay, and you can use, as you told in between, we have to use uterine tonics. You have to do some surgical maneuvers. You have to involve level 1 infuser, so that you are giving the fluids very fast. Okay, then a role of cell saver, then antifibrinolytics, use of focused and replacement of the blood and blood products by use of thromboelastography on rotum. Okay, and use of 1:1:1, so that you are because usually this is isovolemic loss. Okay, so you have to replace with all 3 products which are being lost, because that was an apparently normal patient and suddenly bled like anything, so you have to replace everything. Okay, what else? Point of care hemoglobin, use of intra-arterial blood pressure monitoring. So these all will be the things which will help you in managing in this scenario. Some of the factors are focused, use of multidisciplinary team, involvement of surgical team, involvement of radiologist, packing, surgical maneuvers. Okay, and then last, what else we have missed? I have not mentioned one thing intentionally. What is that? If you are talking about, I have talked about antifibrinolytic. Can anyone tell what drug I have missed?
Recombinant factor 7A.
Very good, Nova 7. Okay, thromboxane A, this tranexamic acid I have told you. Okay, So Novosan is the one which we can use. Calcium, Jamil told. So you are not only you are anticipating the problem because of bleeding, you are anticipating the things which you are creating. Like one of them is dilutional coagulopathy. Okay, one of them is hypothermia induced problems. One are the problems related to massive blood transfusion. What are the common complications which you will be seeing immediately, Zishan, by massive blood transfusion?
Number one, hypothermia. Number
Okay.
two, electrolyte abnormalities.
Very good. What else?
The hypokalemia and hypocalcemia.
Okay.
Then this dilutional coagulopathy
Reaction.
and hematological reactions.
Yes, overload. A patient can even go in volume overload. Okay.
Yes, sir.
Taco, trolley. This will be gradually over. Like it can happen gradually with accordingly. So immediately these problems you can face. Okay. What else? Anything else?
The use of different uterotonics.
Okay, we have missed, yes, use of oxytocin. What is the mechanism of action of oxytocin? What is oxytocin?
It increases the tone of the smooth muscle of the uterus.
Okay, what is the nature of oxytocin? What is it? From where it is released?
Pituitary. Pituitary.
Yeah.
It's a
Posterior
peptide.
pituitary.
It's a peptide released from
Peptide
posterior.
hormones. It's stored in the posterior pituitary, and it secretions is during the labor. And
Yes. What other hormone is structurally related to oxytocin?
I think vasopressin, desmopressin is
ADH. ADH.
sorry?
ADH is friend. Desmopressin is synthetic. We are talking about
Okay.
hormone. Hormone is
Misoprostol.
Is the peptide also similar to the oxytocin, but
yes.
has a different
Okay,
mechanism.
so how much dose you should give? What are the problems related to oxytocin?
Usually we start with 3 to 5
3 milligram in titration dose, 2 to 3 maximum. In
What is that? What unit? With what unit? What unit do you tell?
International units, 3 international units.
3 to 5 international units, bolus, and then infusion 10 units per hour.
Yes, sir.
Yes, 5 to 10 units per hour.
If you give a bigger bolus, what can happen?
Hypotension and tachycardia due to
volume overload,
vasodilatations,
hypotension, arrhythmias. Okay.
Arrhythmias.
Oh, okay. And so which patients, in which patient groups you will be more cautious?
Patient is for hemodynamically unstable, patient with tachycardia, or patient already.
First thing, you have to be very pinpoint. You should be thinking the first thing will be any condition in which patient is already having volume overload. Okay.
Mitral stenosis.
Mitral, like any condition in which there is fixed cardiac output state and patient circulation is already overloaded, so you are making the patient more load and more more stress. Okay, so these patients, valvular heart disease, cardiomyopathies, in these patients you have to be more careful. Okay. And what else? Okay, so oxytocin you try not to give in high dose. There is one a new medicine which is Jamil, you don't have to tell. I will because you know about it. There is one more medicine which is a grip of oxytocin. It is longer acting and it has less stress than oxytocin. What is the name of it? No, not ergot. Zishan, you know about it?
No, sir.
Its name is Carbocrost. Okay, its name is Carbocrost, and its trade name is Pebal. It's it's longer acting. It's given in a single bolus dose. Pabal, not Papal. It's Pabal, Jamil. Okay, So this is a separate medicine, a group of, so some messages are coming, so I'm attending that messages as well. So Carbocrost is prostaglandin, okay. Misoprostol is also prostaglandin. PGF2 alpha is also prostaglandin. And ergometrine, this methergin which we give is ergot. So that is a separate thing, okay. So what about this? So I think these points which you should be knowing about oxytocin. It should not be given in a big bolus. Maximum, you should try to avoid more than 3 to 5 international units, and you have to put it in the slow infusion. Okay.
There are obstetricians all across Pakistan. They use 10
Forget
units.
about them. Forget about them. You are in exam mode.
What is your practice, sir?
No, we don't.
Yeah, mostly the practice in 10 unit, but recommended is 3 incremented boluses each 3 international units, or you
Yes.
can 3 to 5. Okay, in elective cases, but in emergency CS, you can give 3 boluses, like 3 milligram, 3 international units, or 5 into boluses. The total 10, but you should not give 10 international units immediate in the stat.
Yes. Anyways, there is no fixed rule for it. The basic rule,
Yeah, but
even if they are
better
asking,
avoid,
in
yeah, 10 units.
the basic concept you should be knowing. You should not be giving in more dose. Okay. So the other medicine is methergin. So what is methergin?
Ergometrine.
Okay. What is the mechanism of action? What are the systemic effects?
It causes high blood pressure.
No, high blood pressure is a non-technical answer. What is the reason for high blood
Hypertension.
pressure? No. What is the reason for hypertension?
So vasoconstriction.
Smooth
Very
muscle
good.
contraction.
Very good. Vasoconstriction. Okay. So that's why it's not being used in which common condition?
Preeclampsia.
Eclamptic or eclamptic patients.
Yes, eclamptic patient, because already there is widespread vasoconstriction, so you have to avoid it. Okay. So this is usually it is given intramuscular or intramyometrial. People off record, they also give slow infusion. Practically, it can be given, but theoretically you don't have to mention. It's given usually intramuscular or intramyometrial. Okay. And okay. So what about Carbocrost?
Carbocrost is also given IM 250 micrograms.
PGF2 alpha. Okay. So in which what is the problem with it? It causes what?
Bronchoconstriction.
Bronchoconstriction. Okay. So you have to avoid it asthma. And okay, what else? Misoprostol. Misoprostol is usually provided with combination of with the diclofenac, and it is placed where? Per vaginal or per rectal?
Rectal. 100 milligram, 4 to 5 tablets per rectum.
100 milligram or 100 microgram?
1000, I think, microgram.
1000 micrograms.
Just confirm it. I don't remember it. Okay.
Yes, 1000 microgram per rectum. It's 5 tablets per rectum. And
It's also available alone, sir,
it
without
can cause
diclofenac.
the hyperpyrexia, it can cause the fever after.
Okay. So what are the other ways for mechanical? Actually, it's a surgical way. There is one B-Lynch suture. There is uterine massage. There is a role of hysterectomy, use of ligation of internal iliac vessel, embolization of internal iliac vessel, Bakri balloon. Bakri balloon is placed and it is like causing stoppage of bleeding with the pressure. Okay. So these are the things which are being used. And you have to, when you are telling, you should be telling because there are certain different conditions which can be precipitated in this scenario. Like patient can have any coagulation problem like hemophilia. It was not diagnosed. Von Willebrand disease, it was not diagnosed, and suddenly patient is going, despite everything, patient is bleeding. So that's why you have to be, you have to tell that you will be sending the labs. You have to do some point of care testing. Okay. And then you have to consult medical physician if needed. hematologist, and further management will be guided accordingly. Okay. So emergency management will be packing, call for help, massive transfusion protocol as we discussed. And whatever question they will be asking you, even in MCQs or in written exam or in Viva, will be revolving around what we have discussed. Only that you have to choose when they are asking such question in MCQs. Remember one thing, that it doesn't matter mean that other thing is wrong. You have to choose according to the STEM. You have to choose the best answer, the first thing to do. So you have to be logical in that thing. Okay. So these are the points on which they can make a MCQ. So what else? Any other question from junior people? Anyone wants to ask anything? Munazza, would you like to share something? Anyone else wants to say anything about obstetric hemorrhage? Yes, Hassan.
Sir, kindly I want to ask, is there a specific guideline for post-cesarean infusion of oxytocin? What is the exact dose? Like,
listen,
5
actually,
to 10 units per hour.
Yes, it's 5 to 10 units per hour. But I tell you something, that you should know the basic concept. The basic concept is try to give in infusion rather than bolus. Okay.
Right.
And you try to avoid higher doses. There are different protocols. If someone is asking you, say there is different protocols which is being followed from the our college or obstetric college, obstetrician college or obstetricians. So the basic principle is like that, and there is no fixed rule. You have to anticipate according to the situation you are facing. Okay.
Right.
If it is if it is uterine rupture, of course there will be a laparoscopic or open management. Okay. It will be according to the decision discussion with the surgeon. Okay. Let me show you, because I have a lot of things which sometimes are not. Yes, Munazza.
Assalamu alaikum. Sir, I want to ask a question.
Yes.
What's the best time to use injection tranexamic acid if a patient is placenta previa? Is it more beneficial if we use preoperatively?
Just tell me one thing. What is the mechanism now? You have to answer first question, that what is the mechanism of action of tranexamic acid? Who will tell? Zishan, what is the or Munazza, if you cannot recall, Zishan, what is the mechanism of action of tranexamic acid?
Sir,
Jamil.
Sir, it's actually a fibrin stabilizer, and it's increase the strength of the primary clot and inhibit the plasmin. You know, in that way, it inhibits the plasmin, and which help to increase the strength of the primary clot.
So it is antifibrinolytic. Okay.
Antifibrinolytic.
It is inhibiting the formation of plasmin. Okay.
Yes, sir.
So this is the mechanism. So now tell me, if for example patient is having vascular bleed, what will tranexamic acid will do?
Sir, it is, I think the CRASH 2 trial did show that it is recommended in obstetric hemorrhage also.
No, you are absolutely right. I'm not saying, but her question was that should we start preoperatively? So I don't think so. Preoperatively,
that is not recommended.
It will have any role. Okay. when you are managing it in between, in the situation when there is oozing, or they are going towards prevention of DIC. Okay, am I right?
Yes, sir.
Yes, Munazza, are you happy at
Yes,
the
sir.
answer, or anything else is in your
Yes,
mind?
sir. Yes, sir. Answer and clear.
Yes, actually, sometimes some things are, you have a very valid question, okay? But I think apparently till the time you don't control the surgical bleeding, it will not be of much help, okay? So this is data for, this is the guideline for, what is the title for it? It is antepartum hemorrhage, okay? Royal College of Obstetrician and Gynecologist. So it's a slightly older one, but you can, it's in the folder. You can, this one was, Mr. Jamil was telling about these things. These are the risk factors for placenta previa. Sometimes they just create their key from such guidelines, okay? Maybe there will be, if someone has the latest one, maybe there will be some change, but not too much. I don't think so there will be much change. Okay, so hemorrhage from placenta previa. So these can be the complications by any hemorrhage actually. Okay, so now my associated question, not written here is, how will you assess the level of hemorrhage? You are dealing massive obstetric hemorrhage. How will you assess that how much bleeding has occurred?
Number one, there are some objective methods like seeing in the suction bottle, counting the number of gauzes and number of abdominal sponges, and any amount of blood available on the floor. Then there are we classify hemorrhage according to the clinical condition of the patient. We see the respiratory rate, the pulse rate, blood pressure, patient's conscious status. All these things tell us about
Actually,
a rough
sorry,
guide.
you are answering correctly, but only a little bit of alteration you need to do. That we are talking intraoperatively, okay? So intraoperatively, it will be, science will be, or assessment will be different in whether the patient is in general anesthesia or in regional anesthesia. This is one thing, okay? And other thing is that there will be something like, as you told, objectively in the suction bottle, in the this one, if it is cell saver, cell saver can tell you number of gauzes according to the size of the gauze and according to the level of soaking it's been done. On the floor, it's hard to calculate, okay? And then you will go towards a clinical sign symptom, which may be obscured in different scenarios, okay?
Yes, sir.
So other things will be like circulatory changes, and then urine output, mucosa, okay? So
Yes.
that's how you can assess the level of bleeding. And then you can have point of care. There can be, if you are working in a scenario where you have a real-time assessment via the hemoglobin, there is some machine, I forgot the name. Jamil, can you just tell the name? Huh?
HemoQ.
HemoQ is something else. There is one machine like pulse oximeter, and it is telling the real-time hemoglobin. Okay.
I don't know about that, but HemoQ, I think it is just like a glucometer. It tells a point of care hemoglobin.
Yeah, that is something else. That is something else. This is, and another thing is that cardiac output monitor, if you have, or if you, even in some of the modern monitors, there is a very a number of stroke volume variation. Stroke volume variation. This will also be telling you the volume status. Okay. Volume status of the patient, and then you will be acting accordingly. Okay. So any other question or any other concern related to this topic? Anyone wants to share anything? Any question? Okay. So I think we will finish our discussion today on this note, and we will discuss from here on tomorrow. Okay. Any question before we finish?
Sir, I want to ask that is there any limit of allowable hemoglobin range, allowable blood loss? What is the cutoff limit if patient is hemodynamically stable? At what point we will go for transfusion?
Yes, it's a just you try to answer it first, and then we will correct it. Let him answer. You know, usually why hemoglobin is important? Why you need hemoglobin?
We need it for oxygenation at cellular level.
Like hemoglobin is
So-
the car in which oxygen
Sir.
is traveling throughout the body. Am I right?
Right, sir.
So this is first thing. Number one. Number two, the different patient will be needing, like if you have a cardiac patient, okay,
Sir.
which is having more requirement of oxygen.
Sir.
In the sense that the patient is already under stress. So this patient is not tolerating lower hemoglobins. Okay.
Sir.
Then another thing is that like it will also depend on the way the bleeding is occurring. For example, bleeding is constant. Okay. You will be starting the transfusion earlier, because if you will not correct it, the patient will go. Okay. The patient will collapse. So there is no single parameter according to the age, sex, condition, comorbidities, scenario in which you are facing. Usually class 3 or 4 hemorrhage require blood transfusion. Okay.
Sir.
Can anyone improve? Any other concern in it? Like anyone wants to add to it, this answer? Yes, Jamil.
Sir, if there is no comorbid, and can we set the limit to we'll wait till hemoglobin 7, and there is no signs of hypoxia, hypotension? We continue with crystalloids and
no, because continuing with crystalloids will do further hemodilution. Okay, and will risk the patient to go in DIC. So you have to consider the situation, and then only you can act. Like in this scenario, in which patient has acute volume loss. Okay.
Sir.
Acute volume loss, if it is up to class 3, you have to replace blood. Okay, because at that time maybe the reading is not accurate because of the use of crystalloid. You cannot rely, so you have to rely on the level of bleeding which has occurred. Okay.
Sir.
So this is what I have. Jamil, please say something if you want to add something.
Yes, sir. You are absolutely right. You know, at a certain level, we can give the crystalloid if there is no too much blood loss, or in the start, just to maintain the organ perfusion. But at a certain level, further it will deteriorate all the condition. Definitely, it will dilute all the platelets, all the coagulation factors, platelets, and it works the scenario. Then you have to replace the blood products.
Yes, because actually there is no concept of blood transfusion now. Okay, either you are transfusing PRBCs, either you are either you are transfusing FFPs, you are transfusing crab precipitate, you are transfusing anything like that. Okay, so there is no concept.
I just want to share this. Last week, we received one. The operator is same, just like a glucometer. It's also give immediately result of INR. We immediately also can check how much the
INR thromboelastography, because this was not the domain of that topic, so we did not touch that in detail. But gross ideas use of cell INR, ACT, these are all the things which can help you in a bleeding patient. Stat HemoQ, like Massimo machine, in which there is real-time hemoglobin level which is being shown, and some of the machines, they are telling you a trend. SVR, this stroke volume variation I told you, this is also a guide that, for example, if the number is increasing, it means the patient is having a low volume. Okay, so you have to replace.
Yes.
So there may be some ECG changes. If patient is at risk, maybe patient may be starting to have ischemic changes. So there are so many. It's a very open discussion. Okay, and actually there is no generalized rule. It is an individualized according to the situation. Okay. Okay, everybody, thanks a lot. We will continue our discussion from here tomorrow. Okay, thank you. Bye bye.